Now we are almost at the end of our course. So my longest day to treat the diabetic recurrent detachment, it was a recurrent retinal detachment after treating the diabetic combined RD, and there was large open macular hole. You can see that the whole retina is detached at the macula. Lot of PVR changes, lot of membrane formation. So the hole was almost the size of the disc, 1500. So lot of membranes around the macular hole and lot of PVR changes all around the macula. It was previously a combined retinal detachment, and due to the boggy macula, there was secondary macular hole formation happened. So I tried to remove all the membranes, and it was very much, retina was very friable, and so it should be very gentle to remove the membranes only, not to create any secondary breaks. But the membranes were quite tightly adhered. If you cannot settle the detachment, so it is almost an impossible case for me, because I have committed the patient to settle his retinal detachment. I have to do the complete my surgery after settlement of retina, but still the membranes were totally uh, thickly adhered to the retina, and it was creating so many of peripheral breaks. So I had to do the 360 peripheral retinectomy finally to settle at least the posterior pole. But the problem is there was large macular hole. So what should I do? So the peripheral retina, what was left untreated, like it was not, it was redundant. So I used Phenaciflex loop and mobilized this flap uh, underneath the PFCL and to keep it over the macular hole. That was the idea of doing a modified autologous retinal graft, because the peripheral retina, which was little bit is not useful for any kind of purpose. So this kind of situation may happen in your surgery. So secondary macular hole formation in post-op period in a boggy macula, that may happen. So that kind of large macular break, it is secondary macular break, it will not go with the ILM peeling. So any kind of ILM will produce the macular scar, or finally close the macular hole, but it will end up with this macular scar, but you cannot close the hole. So I have the longer follow-up patient also, this thing follow-up also. So now coming to the complications of the perivalvular block in high myopic patient, like it was a case of cataract with myopic phobioschisis with ERM with vitreomacular traction. I planned for the phaco intraocular lens implantation followed by vitrectomy, ILM peeling, and just see, it was actually pre-planned surgery, and the macula should be absolutely visible, everything should be absolutely clear, but on table, after just removal of the cataract, putting the IOL, just I've seen there is absence of glow and lot of hemorrhage. So from where the hemorrhage has come, patient was high myop, so there was a chunk of blood was there inferiorly, so I tried to remove the blood, and finally the this thick highlight phase, thick highlight subhighlight blood has been removed gently without creating, because the underlying retina is thin, and after clearing all the blood, I discovered, just see what happened. Discovered a slit-like break inferiorly and localized like subretinal hemorrhage. So I planned for the, there was a suspicion of, strong suspicion of intraocular perforation. So what I was used to, supposed to perform, it is the removal of the ERM and ILM. So as the patient was high myop and the extensive macular degeneration was there, I tried to stain the macula under ear. It was an old video. Nowadays, I'm not staining the macula under ear. So again, I put the infusion on, keeping in mind that it may cause jet injury. So I put my infusion, this soft tip cannula just overlaying the infusion port, but still it has created superior retinal detachment. So just see, there are multiple breaks in the superiorly, but macula was nicely stained. So I kept my patients, remove all the ERM and the ILM part nicely, because finally you have to show the patient that your ERM is not there, phobioschisis, and ultimately resolved. So I removed all the ERM and ILM, and but still inferior break is there, superiorly localized detachment is there, you have to tackle later on. So that macular part is over. Now you can detect there is subretinal air, 2-3 breaks are there in the superior at 12 o'clock. Now I unified all the breaks because these are the all primary breaks happened during the block, perivalvular block that anesthetist has given. But there is always, it's not blaming anybody, but it may happen in your hand also. So that's the almost inevitable complications can happen during the doing perivalvular block in a case of high myo. So I bandaged all the breaks and injected, keep the eye under air, and finally just see macula has improved, vision finally improved to 612, and after 4 weeks, 6 weeks, the vision ultimately 6.99, retina is absolutely nicely attached, and the whole the sky spot is gone over. So this is my another case of complication which happened during the due to the inadequate perivalvular block intraoperative foveal, because there was subfoveal PFCL and it was silicone oil field eye, vision was 20/120, and my plan was to remove oil and remove the subfoveal PFCL directly. So I'm while trying to remove this subfoveal PFCL directly with this 41 gauge metallic cannula, I saw this jerky movements happening. So I didn't, I just ignored the situation and I didn't respect the situation. I just tried to remove this oil, and what happened, just there was bleeding from the almost foveal margin. You can see, I don't know, I don't have intraocular OCT. So I finally stopped my surgery. So I planned for this sub 10 ounce anesthesia that is very much helpful in a case of high myop or any case of this kind of situation. This subtenuous anesthesia is very much helpful. So I removed this PFCL, this subfoveal PFCL, and PFCL bubble has been nicely removed. But you have to tackle this foveal tear. So I stained the ILM and try to cover up this foveal break with this help of ILM flap, and kept all this whole part of the foveal tear, because I was not sure whether it has created the foveal tear or not. But still, when the subfoveal PFCL has come out, so that means there is some breach in continuity with the retina. So finally, I could have saved my face. I had saved my face in front of the patient. Just see, there is no break and no subfoveal PFCL also. Thank you.